or and also sort of through genuine widespread awareness, maybe there is a bit more like interpretation, maybe there is a bit more worry about this. These are all sort of valid concerns, and it's good to investigate them, but these cannot explain the full extent of the change that we've seen.
Coba itu ada berapa menit? Lepas dulu. Berapa
This is
persen?
kind of, that was my intro, a
72.
bit longer.
Enggak apa-apa, nanti
For the
kalau
rest
pas
of
panjang
the
kamu
presentation, I want to touch very briefly again on the state of youth mental health in Indonesia and Australia, explain why economists should care about it, and then give some examples of how we can use data to support the study of youth mental health. And that's talking then specifically about my work that I do as a data analyst for Headspace. Alright, Indonesia. Yeah.
Would you please use the
Microphone. Yes. Better? Oh, sorry. You should have mentioned that at the start. Sorry. Okay. Indonesia. Coming back to the survey study that was conducted in 2021. It was a cross-sectional national survey that covered over 6,500 households in 34 provinces, and 10 to 17-year-olds and their caregivers were interviewed. So this is, I guess, a slightly younger age range than what I usually mean when I say youth mental health for Headspace. Youth mental health is ages 12 to 25. The reason for that is that it goes beyond 18, is because the human brain still develops until about age 25. And so if you, some of your most significant challenges with your mental well-being and the disorders that you can experience happen right around that point when you turn 18, 17, 18. And then it's quite important to have continuity of care and not be sort of kicked out of the child services. You have to find an adult service. So the idea is that for young people, there's a continuous development, and that should be reflected in the services. But this is a good sort of approximation because quite many young people fall into the 10 to 17-year-old age range. And this study found that 1 in 3 adolescents showed symptoms of mental disorder in the past year, but they didn't have a full threshold mental disorder. So they had signs and symptoms of depression and anxiety, for instance, but they didn't fully qualify for depressive disorder or anxiety disorder. That applied to 5.5% in this sample. Now, also I guess important to note is that this is just asking about the past year, so it doesn't mean that these people couldn't have, like the incidence would be much higher if we talk about the lifetime experience. They're still young, so lifetime is not that long, but you know, every sort of, you could have had an experience earlier as well. Anxiety disorder was the most common disorder, followed by major depressive disorder, conduct disorder, and post-traumatic syndrome disorder, ADHD. And in this study, interestingly, we did not see any differences in prevalence between males and females, or younger and older adolescents. And I say this is interesting because, at least from my perspective, from the Headspace data in Australia, we have a huge overrepresentation of female young people who come and seek help at our services. Another question is that because they're experiencing more issues, or are they just smarter and seek help earlier? But yeah, I guess that's always an empirical question, and here, in this study at least, at the national level, there were no differences between boys and girls. In Australia, mental disorder prevalence is 7 times higher. So we just saw the stat that it was 5.5% in Indonesia. In Australia, it's closer to 40%. We also have suicide as the leading cause of death among young Australians. And the rates of mental illness and suicide are generally affecting more marginalized communities more than other communities, the general population, something that economists care about. So yeah, all good reasons to provide services to stop this from happening. Why should economists care about youth mental health? It's really quite simple. 75% of mental health problems start before the age of 25, and they will have lasting effects on your lifetime if they're untreated. It affects education, relationships, future earnings, and it's also mental health problems are the leading cause of disability in young people worldwide. That's mainly because young people don't get sort of other diseases or don't get injuries, but that's why it's all the more important that we take care of the mind and the mental well-being of young people. And also, sort of, I guess the flip side of all this is that any early intervention and prevention can have really huge positive benefits that we don't really, that they might be a bit hard to quantify, but they build up over time as well, and that's definitely something that should be taken into account. Perhaps some economic cost concepts, that we can think about. These are just a couple of factors that would be affected by mental ill health. Education could be affected by earlier dropout, lower attainment, employment outcomes could be unemployment or lower wages because you're not functioning at your best. Productivity loss is there because of people not showing up, unable to work, or coming to work when they're sick, which is also not great. And they also have a higher lifetime cost of healthcare. I'll leave the reflection for now. You can take that home with you. We won't do the meta-meter for that one, but we might come back to that later on. And I'll just go to how could we measure these costs or this burden of the disease. Well, some of the things that I have in the previous slides can be categorized as direct costs. So healthcare usage is something that we can measure directly. We know exactly how much it costs to go to the GP, to go to the psychologist and psychiatrist. Lost productivity is an indirect cost. It's a bit harder to measure, but we can do that at an aggregate level once we know how many people worked and what the time frame is. But there are also some intangible costs, especially, what's the benefit of well-being or the cost of poor well-being, or suicide, which is of course a life that's lost, but it also has a huge impact on the family and the friends of the person who died by suicide. So for Australia, I found an estimate that the economic cost of mental ill health and suicide in young people was $43 to $70 billion. I think that was in 2020, but that does not even include these intangible costs, so this is just the direct economic cost. But perhaps this is really hard to compare to Indonesia, because it's also in Australian dollars, and hard to compare. Another way to compare this burden of disease across different countries, different contexts, is to use either quality-adjusted life years or disability-adjusted life years, DALYs, to quantify the burden. And I'm not sure if you've heard about this before in the health economics class. A disability-adjusted life year is basically counting how many years did you lose to disability because of the disease that you have, the mental illness, and how many years do you die earlier. So that's the kind of the sum for this. And if we look at that, you can think about it as a depressive disorder would perhaps stop you from working half the time perhaps, or maybe 1 week out of the month, then that contributes to a quarter of a year of disability that you lost over a year. So once we compare these estimates from the World Health Organization, we can see, I don't know, this is a bit small, I'm sorry. We can see the top 10 causes of disability-adjusted life years And here we see in Australia, the top bar, is depressive disorders. The second one is anxiety disorders. So this is clearly the leading cause of DALIs that we lose in Australia every year in this age group. Other categories are self-harm, it's the dark blue one, eating disorders down here, and bipolar disorder. So I'd say a good chunk out of these are all mental disorders. In Indonesia, on the other hand, the top one is road injury, and perhaps that's not a surprise, but you also see anxiety disorders is the first blue one under the green bars, and depressive disorders is down there as well. And one of them is COVID-19, so this one will be gone now in the new data update. So that actually makes anxiety disorders, brings that into the top 5 in Indonesia for disability adjusted life years lost. But also we can see a little bit the scale of the difference. So in Australia, depressive disorders account for about 1,200 DALIs, and in Indonesia it would be 450. So different scales, not quite the same as the other data, but it shows again that there's to some extent a difference in prevalence, which can potentially be explained by different data sources that are used, but also perhaps just different issues, being at a different stage in recognizing and awareness about youth mental health. Okay, next I want to talk a little bit about Australia's response to the youth mental health crisis and my work then. So Australia has for quite a long time recognized youth mental health as an important issue, because there was already, 2006 is when my organization was founded. There was just not enough services that young people could access, because psychiatrists and psychologists for adults were just completely booked out. But they also didn't need to see a psychiatrist, they just needed someone to talk about their sort of pre-disorder symptoms. It's something that I mentioned at the start. In the Indonesian survey, there were 1/3 of all young people didn't qualify for mental disorder, but already showed signs of depression and anxiety. So this is exactly the stage where its early intervention can help and can reduce this and prevent this from developing into a disorder. So currently, there's a large public investment in mental health care in Australia, and it also has bipartisan support, and youth mental health is recognised specifically as important. And our service is kind of the main service provider in Australia. We have over 160 centres across Australia and provide a platform for different types of services. And the idea is that they're all youth-specific and youth-led. So we have young people advise us on everything. We have a no wrong draw policy. You can come in with any problem. And if the rule is if we can't help you, we'll find a referral for you, we'll send you somewhere else. We're also a one-stop shop, so we're integrating not just mental health support, but work and study support as well. Because maybe this is relevant for university students. Work and study and mental health issues often go hand in hand. One is impacting the other, and the other way around. There's a double causality from both of them, reverse causality. So if a service can provide, you identify this, that educational support or help in finding a job can actually make your mental health outcomes better. So, perhaps I can skip this quite quickly. Just a bit of a vision, which is, I know is not the reality in Indonesia, but the vision is that all young people are supported to be mentally healthy and engaged in their communities, and that young people can access the right support when they need it and how they want it. So we have stuff that's digital, we have stuff that's physical centered, and have different support programs. For instance, going to universities and preparing university educators for suicides that might happen at the university and how they can support their student well-being in the aftermath. Okay, these are just the wraparound services, but I guess the main reason why I'm sort of telling you about this is just to illustrate that sort of once you have a bit of a platform or grown into a bigger service, you can collect data and we can use these data to analyze youth mental health at a national level and provide advocacy. Okay, this is what it looks like in a Headspace Centre, very friendly. And now perhaps to the data analytic part. So how can we use data from a service like Headspace, that's a national service provider, to study youth mental health? There are a couple of ways. I'm not sure about your methods background, but I'm sure everyone has had some statistics in their economics course. So we can do descriptive analysis, maybe to study the prevalence of youth mental health issues. And an example of that is just describing the incidence of suicidality. In the data that we see a quarter of young people experience suicidality or come because of suicidality that they experience. And that's hugely important to know about, because it also means that service providers need to be prepared for that. That this is not uncommon. Suicidality is not something that affects 1 in 100 people. It's something that potentially crosses every fourth person's mind. Then we can use regression analysis to study more how suicidality, for instance, is correlated with young people characteristics. And we find that especially marginalized communities like LGBT young people have an extremely high risk of suicidality. And we can do something a little bit more advanced. We can use machine learning methods to do like a data-driven analysis of complexity in mental health. I guess we're at a stage where not everything is just anxiety and depressive symptoms, but we also have things like that affect your mental health that make it more complex. Is if you're experiencing housing issues, which is something that's of growing concern in the cost of living crisis, and a young person who's experiencing homelessness, for instance, would have an added layer of complexity in their mental health journey. Just sort of moving on from descriptive analysis, we can also use a causal analysis framework to study the determinants of youth mental health crisis and of outcomes of accessing services. And here I will show you one example just after this slide of an econometric analysis of natural disasters and how that has influenced help seeking and youth mental health. And we can exploit things like random variation or policies that are being made to have this quasi-experimental analysis that allows us to study, for instance, the impact of social media on youth mental health. And I'm quite excited about this. Maybe that's the wrong word, because I should care about how it impacts the young people. But from a analysis point of view, the Australian government is in the process of banning social media for under 16-year-olds. And perhaps this is also a nice discussion question for the class. How would you feel about this? With the idea that social media access is harmful to young people's mental health, and especially young adolescents under the age of 16 cannot really control what they see or how they engage with it and sort of get addicted to it. But the policy solution is a sort of blanket ban for everyone, which is not clear that this is the right solution. And we need economists, someone with the training in analysis and to actually analyze this. All right, enough number of individual services that we provided across Australia changed after this bushfire, which was in Perth in 2021. And you can see sort of here, this half of the graph is sort of the average treatment effect before the bushfire happened. So we see that the red line centers around 0. There was no difference in the centers that were affected by the bushfire before the bushfire happened. But after the bushfire happened, once we compare the centers near this bushfire, we see a jump in help seeking, in mental health problems. So young people, after experiencing a natural disaster, these centers provided on average 50 extra services each week, which means that I think in terms of that's almost equivalent to the number of young people that came through and wanted to talk about their mental health in the aftermath of the bushfire. And we can use the data to really sort of show this as a causal effect in this difference and differences analysis. This was a different one, a tropical cyclone, and you can also see in the weeks before the cyclone happened, there's no difference that you can detect between the affected centres and others, the rest of the country, but after the cyclone it jumped up and the number of serviced young people stayed higher for quite a long time, for quite an elevated period. So this is a causal estimate of the effect of natural disasters. We can also see that we have some data on why young people come to seek help. So some of these data items are related to climate change. And we see that there is some indication that it's actually the fire that's driving this in terms of the climate anxiety impact. But another, I guess the most dominant channel through which the cyclone is impacting the young people is the impact on displacement or the repairs that they have, perhaps tensions in the family after a disaster. All these kinds of different things, again, contribute to experiencing mental distress. So these examples were relatively clear. I'm going to show you one where it's not that clear, but it's still good to look at the data and to try to get through this. This is data from the Black Summer bushfires in 2019-2020, which was a very devastating series of bushfires. So much more widespread, and that had much bigger consequences. More people were displaced and couldn't live in tents or in temporary accommodation for a while, and had sort of more direct, immediate impacts of the natural disaster. And when this happens, we see that the effect on the number of services is not as clear. It first actually goes down in the weeks immediately after the fires, because everybody's busy trying to find a place where they can live and rebuild and get that back on track. And only after about a month or so, this line starts to creep up above the 0 line, and it stays insignificant for a while compared to the pre-fire period. But after, I think it's 16 weeks here, we actually see a significant increase. So we have a delayed help seeking after a significant natural disaster event, and this is actually in line with sort of clinical insights as well about help seeking. We do see in this disaster that psychological distress goes up right from the start. So we have delayed help seeking, but distress goes up immediately. Okay. To sum up a bit of what I wanted to convey to you today, first of all, youth mental health is important, and it's a growing problem across the world. There are various factors that contribute to it, and we need better data and better analysis to understand these factors spread this awareness and spread this further so that it can be addressed meaningfully. Great. I want to stop here with my presentation. We do have lots of time left. I think I sped up a little bit. We can go back to the Mentimeter as well and go back to the reflection that I had on there. And then I'm also more than happy to answer any questions that you might have. I just put on the slide kind of, it's a bit outdated now, but 7 tips for a healthy fit space. It's very simple, very, very simple, but just have a look at it. If you want, you can, everybody can make some small changes in their own lives to protect their own mental health through small habits. Thank you. Thank you.
Okay, thank you, Sabrina. So it's time for questions. Oke. Teman-teman, kalau ada pertanyaan silahkan loh, boleh dalam bahasa Indonesia, nanti saya translate ke bahasa Inggris, atau mau langsung dengan bahasa Inggris juga. Ya. Sebentar Mbak, pakai mic ini sambil.
Langsung ambil aja. Tadi.
Mungkin bisa sebutkan nama.
Thank you for the presentation. I'm Aziza. I'm not from FAB. I'm an adult learner tutor, and my students, including social worker. So these kind of issues. I want to ask how would you include green space issues in youth mental health, well, in mental health in general, because there's always a drive to economic growth. Let's turn green space into concrete space. Then how would you advise on that? And are there examples of evolution of that, where the economic growth in other countries, perhaps Scandinavia or that, is changed from concrete to some more green space and with good economic effect. Thank you.
Thank you. It's a great question. And yeah, I know you're referring to the positive effect of green space on mental health, and that's really important. You're right. There's not much green space around. I think one sort of, I guess, strategy that I know from the clinical practice side of things is that there are different ways of finding green space within your limited context. So it doesn't have to be a park, or it doesn't have to be a forest. It can be sort of caring for plants in your home as well, which has proven positive effects. I know it's not what you mean, but this is just the clinical practice sort of perspective on how you can work with the context that you have. But perhaps a better answer directly to your question is, I know in Paris, for instance, there has been a change from going from concrete squares that have paved squares in front of the city hall, for instance, to planting like a mini, not a forest, but planting trees and other plants in front of the city hall, which created a massive big green space. Now, I don't think that the reason for that was necessarily the mental health reason. It could have been, I think it was more related to environmental reasons, climate change, and also sort of because, plants cool down the air compared to concrete. But it would be an interesting study to actually look at what's the mental health effect of that change in the Paris urban infrastructure. Can we actually see that this has not only impacted, like environmental variables like the temperature or the pollution levels and stuff like this, but has it actually made a positive impact on the mental well-being of Parisians? And I'm sure you would find
Ada yang lain?
So my question is like, to what extent do you think would banning or restricting social media access for young people in Australia reduce mental health issues, and how might such restrictions still offer the same opportunities as not banning the social media itself? Duncan.
I'll repeat it to make sure I understood correctly. So about the social media ban and how perhaps other solutions could.
Or is there any solution that gave the same opportunity for young people because
To
of
express themselves,
Yeah.
to access it,
Yes.
yeah. Yes, it's a very good question. I'm sure there must be more nuanced policy measures. This is a very blanket tool applying to everyone, and it's cutting off important ways to connect with other people for these young people, especially for young people who live in rural areas, for instance, and they have less opportunity to connect with others, and they go online to do that, or marginalized groups. So this is a very big sort of topic of discussion. I think that the literature is a bit unclear about whether the effect of social media is positive or negative, or it's a mix of everything, and there's some balance in there. I'm sure that the government could find a better solution, but it's I guess harder to find a better solution and to implement a better solution, because it requires perhaps regulation of the companies, of the content that they're posting. Rather than restricting access, you could restrict the content to make sure there's no harmful content. But that's harder to do, I think. So my perspective is that it's a political sort of thing. Like, it's a bit easier to roll out a ban and require some age verification and things like this. But to be honest, it's also still a question how effective it will be, because age verification mechanisms can be circumvented. They don't function perfectly.
Oke, berikutnya.
Hello, Miss. Okay, so I wanted to ask, okay, and I don't know if this is a very great question, but here in Indonesia, actually mental health illness is associated with you being not religious enough. So you're too far from God. And so you, in Indonesia, we say, kamu kurang sholat, you didn't pray enough, and you're not close enough. And so I really wanted to like address this. I feel like I have seen a lot of my friends dealing with mental illness, and again, they're ashamed of seeking for help, and to be diagnosed with mental illness, they felt ashamed to even like ask for help from their friends, because the stigma of you are not close enough to God. And I wanted to know, how can this actually affect youth, young adolescents in the future, because they're so afraid to express themselves because of how the stigma around the society, and a lot of parents are like, it's not a big deal. And of course, the previous generation would say, I have been through that issue. We went to war and we're fine, and we don't have anxiety problems. And why are you so? Let's just say you're so lame, you're weak. And so, is there any like a very bad long-term effect that will happen? Thank you.
Thank you. It's also a very good question. I think yeah, I can totally relate to what you said. It's the same in other countries. There might not be religion in other countries, but the thing about the older generation saying, you know, we went to war, we had other problems to deal with, that's definitely also something that's common in other countries. I think it's a generational shift that's happening, and so I think the sad answer is that for your generation, probably you're the generation that brings the awareness, that starts the societal shift. And you can already, just the fact that you spoke up about it, you explained it to me in this class, means that already something is happening, right? And think about your children, how you will parent your children if you're choosing to have children later on. This will then impact the next generation. So the next generation will be further advanced again. And I think this is perhaps what's happening across different countries. They're just on different timelines, different trajectories in the kind of the same development of the society, where awareness grows, perhaps other problems diminish a bit in size as well. You know, it's kind of, I can see that this is really hard at the moment to balance this, being in the situation where you have the awareness and you're struggling with it, and you know that it's got nothing to do with perhaps your religiosity, but you cannot, it's not accepted in the society as a whole as yet. It's really hard to deal with that. I think what you have to do is sort of find your little, your safe space, I guess. And that could be online, potentially. It could be something that happens by connecting even with people outside of Indonesia.
Thank you so much.
Do you still have time for questions?
Yeah, sure.
Ada lagi? Ya, silakan.
Thank you, Ms. Sabina, for the presentation. It's very interesting. My name is Bahira, and I'm interested about what you do in the Impact Evaluation Department of Headspace. Could you tell us a bit maybe about your projects or what you have done in that department specifically? Thank you.
Yeah, thank you. My pleasure. I'd like to tell you more about it. So I work in a team with mostly evaluators, actually, people with not a quantitative economics background, but with evaluation background. We work, I guess it's a mixed methods kind of team. We apply different lenses to it, but the idea is that, so Headspace has grown into a really, really large organization with lots of different programs. Every new program that starts, or every existing program that runs, needs to be evaluated because we rely on government funding. And one requirement for the funding is that there's an evaluation report that shows that sort of what they wanted to give the funding for was actually what also happened, what we used it for, and they also want to see outcomes, the effectiveness of the services that we provide. So what I do is I do the data analysis for the team. Other team members also have statistics skills. They often sort of collect survey data specifically to answer the more specific questions about the programs. What I do is I look at the full data that we have. I have access to basically every single interaction that the young person has with like a service provider. It could be a therapist, could be a GP or a psychiatrist, and I can sort of see how that changes over time, or how different groups of young people access services. So I did a study on multicultural young people in Australia, actually. So I looked specifically at what their service experience is, and if they accessed different types of services. I found that multicultural young people were older than other young people, in part because of their delaying help seeking. A little bit what you said, there's perhaps a bit more stigma or other reasons. They have other reasons for why they can't seek help. more, sort of understanding perhaps. In a similar way, similar style as I've looked at peer work data. We employ peer workers, which are young people or not young in the right age range anymore, but people who had a mental illness in their youth. And they now work for Headspace and provide sort of their lived experience and help others through this. And I see that makes a massive difference in the outcomes, because it means, you see someone, you talk to someone who's actually experienced that. These are very descriptive examples that I gave you. I had some where I did some cohort studies, matched case control studies, for instance, where I look at a specific program and what the mental health outcomes were from going through that program compared to going through a standard service. I use a variety of different things. And in the future, I hope to link our data with administrative data from Australia, which would allow us to study the long-term outcomes. Because at the moment, we're quite limited by, we see young people and they come for a certain number of times, and every time we ask them some questions, or every time we get a little bit of data from them. But when they no longer come, we don't know what happens to them. So sometimes we do like a follow-up survey, but that has a low response rate. So I want to link our data to Australian administrative data from the government, so that I can actually follow these young people who came to Headspace much longer and see what are their health outcomes, what are their education outcomes, what are their economic outcomes from accessing these services.
Lagi mungkin dari sini, sebelah sini. Ini soal mana ini? Suaranya. Ayo. Go. Hah? Sama? Oh, benar. Oh ya, Mas, silakan. Tolong.
Okay, thank you for the as a economist perspective, we know that the challenge and limitation of the data of mental health. I want to know about the constraint about the evidence base to measure the mental health issues, like how we overcome and the data of mental health.
How data can be collected
Yes.
at the government level?
Yes.
Yeah, that's a good question. In Australia, some of these it's service use data, so they get information from how many people access hospital, psychiatric services, or GP or psychologist services. So it's service use data, and that's basically every single service is billed basically, so that the government, the tax office, knows exactly how many psychologist services were provided in the whole country every year. So that's, I guess, one way to estimate it. Then the other way is, I think what we do is we have different departments that run an annual survey, which is then more specific about, you can have more specific questions and not just service use data about the mental health of the population, and that's a random sample of the population. But if they repeat it every year or every 2 years, you start to get sort of a more complete picture and how it develops over time as well.
Okay, so the problem is about the data. Any other questions? Yeah, silakan. Do you still have time? Because it's a very interesting discussion.
Okay, hello. First of all, I really appreciate your presentation. It's really interesting. I want to ask, so I have a mental illness, and after seeing your presentation, like there's an anxiety growing in my mind that with mental illnesses, you have some costs that other people don't cost, like for medical prescriptions maybe, and and all. And I want to ask you, like, do you have any words for me? Because like, I feel like there is a growing anxiety of economic pressure for having a mental illness. Okay, that's all. Thank you.
I think, I'm not sure, can you just repeat what the last question, the last part of the question?
Okay, my question is, do you have any words for me?
Any words?
Yeah.
Because you feel like there's an extra burden from multiple countries. Yeah, I think there's there's a huge impact of having a mental illness. Some of it which is economic, like the cost that you have, right, for buying medication or going to regular checkups and things like this. And I think that's quite important, not to forget about, that it's not just it's an additional struggle. It's not just a mental struggle, it's also a financial struggle as well. I think, it's kind of these, from an economics perspective, it's probably easier to take these costs into account than to take the mental costs and the intangible costs on your well-being and perhaps your relationship with friends and family into account, which is probably why I focused a bit more about that. But I can totally acknowledge and recognize that it's an impact on every aspect of your life, and not just the health side of things, but financially as well. And perhaps what you're able to do in what you're able to experience going through life. So I wish you all the best with that.
Oke, masih ada? Masih boleh ya? Okay, so Amina, I have a question. You mentioned that in Australia, the prevalence of mental health among females higher than men. Can you explain why in Australia happen like that, but not in Indonesia?
I think it's, to be honest, a large part of this I think is due to the help-seeking patterns. So when we look at
so it is easier for men to seek help?
I can see that for my data, I have a huge imbalance. But if you look at nationally representative survey data, there's a smaller difference between boys and girls. So there are some differences, some nuances. So girls are way more affected by social media and say that affects their mental health more negatively than boys. But there's an equal sort of representation of general symptoms among boys and girls. Just that I guess the topics are slightly different. Boys are more have stronger mental health issues with bullying, for instance. And for girls, social media seems to be a more dominant topic. But then the reason why my data is so imbalanced is that the help-seeking, or maybe the awareness or the willingness to go and have a mental health service is very different. So we are working on, I guess, reducing the stigma for boys, young men to come and seek mental health support. It's one of our priority groups actually. It's a bit funny because other priority groups are very marginalized communities, like people with migration background, things like that. But also boys, because they just don't seek help early enough.
So boys more don't care about the situation?
No, I think they think they don't need help. They don't need help from someone else. They think they can work work it out themselves. But we do see that boys disproportionately die by suicide more often than girls. So that's kind of that's if you don't seek help, then this is a pattern that you might expect, because they deal with it more by themselves.
So another question.
Yeah.
Sorry. It is related with the data availability, because in Indonesia, and you mentioned that I also have heard about the survey, but is it free to access the information for the survey for the mental health, for the data for the
survey data?
Yeah, survey data.
It's a good question. I don't know if they're freely available, but it was a collaboration between UGM and UQ actually, and
from the medical
Journal.
science
Yeah, that's right.
faculty. Yeah.
So you could probably reach out to the authors and
because
ask.
it's quite
Yeah.
new.
Yeah, that's right. I saw some presentations about this at the conference, Health Economics Conference as well. Yeah.
Okay. Alright, so ada lagi mungkin komentar juga boleh. Nah, silakan.
Just want to add what I said that maybe we should to increase like awareness about the importance of going to the psychologist, to the people or student at the university level, since when they facing the mental health problem and they don't seek the help from others, then maybe suddenly we hear that someone doing suicide, something like that. Yeah, maybe we should increase what awareness in the university level or school level and so on. I just wondering what kind of the program in Australia to increase the awareness about going to the psychologist to ask the help for in case there is a mental health problem.
Yeah, it's a really important topic at universities, especially as we saw the academic pressures and were really some of the key drivers that people could see as causing problems. So we have, I guess, because Headspace has grown for almost 20 years, 18 years already into a large organization, so we have a little bit of recognition within the population as well, and so what we do is we do awareness, we connect with schools before university level, so that already school counselors are aware of Headspace, and if they have a problem, they sort of carry that awareness to the school population as well. And then at the universities, we have a university support program where experts from my organization come to the universities. They have a sort of one advisor who's allocated to that university, and then they run workshops with the staff to prepare the staff. First of all, to raise awareness and literacy in mental health, to recognize problems, and sort of to not say, the student might come to you but might not have the words to say that they're actually quite desperate. They will just say something else. But if you have a training or a bit of background in mental health, then you might say, okay, hang on, I have to follow up with this student to make sure they're okay. So we have a program that provides training to the university staff, and that's awareness, but also how to respond after suicide happened, and then they can call on the team for more support so that they can come in and do that. But I think it's a good start to maybe have like there's an annual World Mental Health Day. For instance, that could be something that could be celebrated by the university to raise awareness on the whole campus on that day. It could be like a simple thing like this, just something that's is an annual reminder and grows bigger every year, and you could organize some activities around that, stuff like this. But I think the biggest thing is to have that literacy as well among the staff. They're aware of it.
Okay. lagi nggak? Sudah? Ya. Baik, mungkin saya simpulkan sedikit ya tentang sorry yang bahasa Indonesia, so probably they can more easier to understand. Jadi hari ini kita diskusi tentang khususnya tentang kesehatan mental remaja ya, anak muda. Ya. Jadi banyak faktor yang mempengaruhi ya. Jadi ada sosial media, kemudian ada environment, ya, natural disaster, kemudian ada lagi academic pressure, ya, yang kemudian pada saat ini isu tentang kesehatan mental itu menjadi isu yang sangat hangat di komunitas kesehatan. Jadi teman-teman kalau di sini misalnya satu mau riset tentang kesehatan mental, kalau kita punya data itu kalau nggak salah di IFLS itu akan ada questions yang related dengan mental health, itu yang sepanjang saya tahu. Nah ini kemudian ada survei, tapi survei itu dilakukan menjasnya dengan fakultas kedokteran. Ya. Nanti saya bisa coba cari informasi bagaimana kita mengakses data tentang mental health yang mereka lakukan surveinya. Ya. Mudah-mudahan ya siapa tahu bisa beli kalau memang harus dibeli ya, fakultas mau ada anggaran dibeli. Karena ini sangat menarik ya. Terutama kemarin saya ikut di World Congress di Bali, ya Health itu isu tentang mental health itu menjadi fokus dalam kongres itu. Ya, jadi luar biasa isunya. Ya. Oke teman-teman, kalau misalnya masih ada pertanyaan bisa send email ke saya, mungkin nanti masih bisa saya sampaikan ke Sabina. Ya, kalau masih ada komentar atau pertanyaan. Ya. Oke, saya kira itu untuk hari ini. Memang lebih awal, tidak apa-apa ya. Insya Allah minggu depan kita lanjutkan materi dan kita bahas paper yang sudah ada. Ya. Sebelum menutup, thank you Sabina, and we have a souvenir, a little souvenir from us. Masuk semua enggak?